Okay, so we're live here. It's Antonio Chirumbolo with newgradoptometry.com. I'm here tonight with Dr. Nick Despotidis and Dr. Noah Tannen of Eyecare Professionals PC out of Hamilton, New Jersey. And tonight we're going to be talking a little bit about what it takes to create a practice that provides fulfillment inside and outside of optometry. So without further ado, I'm going to hand it over to Dr. D and Dr. Tannen here. And I know they've prepared some stuff they'd like to speak about. And please ask questions, as many questions as you'd like, and we'll get some discussions going. So
That's great. That's great. Well, thank you, Antonio. And thank you to Noah for coming in with me.
Of course, thank you both for having me as well.
Yeah. We planned out something pretty informal. I have like a 30-minute presentation that I give on practice independence, and Noah will join in. Basically, we'll give you a little bit of history of our practice, and that will give you the opportunity to ask some questions. So, our practice right now has been in existence for 30 years. And we're going to try to take you through the journey of these past 30 years. Right now, our practice has 3 partners: Barry Tannen, Noah's dad, Ivan Lee, who's been a full partner for over 15 years, and myself. So Dr. Barry Tannen and I started the practice 30 years cold. Ivan joined us about 15 years ago. And the dates under our names are the years we graduate. So you could see, at least Barry and myself were pretty old. We have Dr. Kelsey Moore. She's doing our practice management and vision therapy residency for a year. It's accredited through Southern College of Optometry. And we've trained approximately 8 residents to date, and we'll talk about why we do that. And Noah has joined our practice just this year. He's only been with us 5 months, and that's what motivated me to ask Antonio to have us on, because it's only been 5 months. So it's nice to ask Noah questions because he's just starting to get into it. And I've been very motivated by his presence because his transition has been remarkably seamless. And it wasn't that when Ivan joined our practice 15 years ago. So this is Barry and I. Noah, were you born in 1988?
I was not. I was still a fetus.
Yes. So you could see, and most of you listening, if you're new grads or relatively new grads, none of you were born. So Barry and I opened up cold. That's the Ninja Turtle, if they still exist. And that's the mayor of our township. And you can see Barry and I in the background. We're pooping in our pants. We really don't know what we're doing. We invested our life savings. I remember when we borrowed money, they had to put a lien on my wife's engagement ring, and they did the same, Noah, with your mom's engagement ring. They liened everything because we had no assets. So we opened up.
I didn't know that part.
Yeah, you could ask your mom or your dad. It was pretty embarrassing.
I believe you.
Yeah, it was pretty embarrassing when I had to get my wife to co-sign and put down everything we had, and we didn't have much. I had graduated in 86. I did a residency in 87, and I was just right out of the box. So now you fast forward, you're just seeing the end product, and hopefully will motivate you to kind of visualize your life, the life you want to be in the future. So right now, 30 years later, I think what's unique about our office is we offer just about every subspecialty except low vision in our office right now. We started out 30 years ago basically as an eyeglass and soft contact lens practice, and the bulk of our income was generated from commodities like glasses, contact lenses, and very little eye exams. Ortho-K wasn't around. I had completed a vision therapy residency, but that first year I wasn't using it. There was no medical treatment. When I went to school at SUNY 82 to 86, we couldn't even use dilating drops. I think we started using them maybe my last year. So that's how old we are, but that's also how much our profession has matured over the years. We have one location, about 5,000 square feet. We don't accept any vision plans. We dropped them about 17 years ago. We're a happy practice. We really are. Most of our staff has stayed with us at least 17 years, but it wasn't always happy. And Noah hopefully will share with you the honesty. It's not happy every day, but for the most part, we run it like a happiness-centered practice. We've grown. We continue to grow, and we hope Noah is going to be part of that growth. And we don't suffer from FOMO. I learned that from Noah. What is FOMO, Noah? Because I'm really old. What's FOMO?
It's an acronym, and it stands for fear of missing out.
Yeah. We don't, and we're going to talk a lot about it.
Yeah, and it's the new lingo that the millennials and the youngsters are using these days.
It's great because we suffer from it, all of us, everybody listening, including myself. In optometry, we suffer for it because we're fear of missing out. If Antonio says to me, hey, Dr. D, I'm fitting Procara lens, we're billing really well. I'm like, oh, I should fit Procara. If Noah tells me, hey, we should be doing more OCTs and other things like that, or fitting scleral lens, I feel I should be doing that. If a colleague of mine says they're selling, I don't know, coach frames and they're flying off the show, I feel I should be doing that. We don't have that anymore. We really have learned from our experience. So you can't see this, but I talk about an inflection curve. I got this from the book Only the Paranoid Survive by Andy Grove. Andy Grove is the co-founder of Intel. And the inflection point is any point in our lives where we're made to make a decision. And it's a critical point in our lives. It could be in our personal lives. It also could be in our professional lives. So listening to this YouTube Live is an inflection point. Most people haven't tuned in. Whoever's listening to us has listened in. So at that point, you're going to have to decide, do I take this information and do something with it, or do I just go back to my merry way? And 99%, unfortunately, decide not to decide. They just decide to go to the flow. And I think that's an opportunity. So let me talk about these inflection points. When Barry and I started in 1988, these were our inflection points in optometry. Buy one, get one free was very hot. Buy one pair of glasses, get two free. I swear to you guys, there was a guy down the road from us buying one pair of glasses, get two pairs of glasses free. Pearl was advertising. Nobody beats Pearl. Buy one, get one free. Nobody cares more than Pearl. So that was what we were up against. Lens crafters just came in existence. Glasses in an hour. The lab was right in there. And believe it or not, we're so old. The autorefractor was relatively new. And I remember as a student, I really was concerned because I was having trouble scoping and doing retinoscopy, saying, gosh darn it, this little computer is it does it within a second and is more accurate than my scoping. So these were our inflection points. They've changed, 10 years later, it was 1-800 contacts, wholesale glasses became a big thing. Discount LASIK was starting to come into play. That's from our penny saver or Sunday paper, $2.99 LASIK. So if you remember that slide up there, we actually used to do LASIK eye surgery within our office. We had a row laser come in, surgeon came in, microkeratome tech came in, and right about 1999, 2000, we realized this is not a good business model, and we just basically stopped. So for everybody listening out there, these are your optometric and ophthalmological inflection points as I see them. It's online refractions, online glasses. It's refractions on your cell phone, ordering contacts from your cell phone, buying glasses online, Warby Parker. That's what I view as optometric inflection points. Also, some insidious ones that you may or may not be aware of. There's a tremendous consolidation within our profession. VSP was bought out by Marchand or vice versa. I don't know who bought who for millions and millions of dollars. So even though we don't accept VSP in our office, I get VSP invoices because we buy Marchand frames. And I'm sure in the future there will be Marchand stores if there's not available. Certainly you'll be able to buy Marchand frames online. And that's an issue because we're just technicians, right? If you accept VSP, you do the eye exam, and the patient will go online or go somewhere else to fill them. Just recently, CVS bought Aetna, I think, for $65 billion. A lot of money. Why? Because it's just a beautiful system. The prescriptions physicians prescribe will be filled by this #1 pharmacy, either online by Caremark or in the store. They pay us Aetna. So we get it both ways. We're controlled both ways. All of you out there have written scripts, and the pharmacist calls and says their insurance doesn't cover Lotamax. Do you have a substitution? So I feel I'm slowly being controlled by forces beyond me because I want to prescribe one medication. The pharmacist is saying to me, what is a substitute? So that's a consolidation. The one that you're probably aware of is Luxottica, owns LensCrafters, owns all the frames, owns iMed, Vision Source recently, which is a buying group. And if you look on the lower right-hand corner, that's Jeff Bezos, Amazon. He's just smiling because he sees a much bigger picture. And my primary concern as a health provider, I don't want to be a technician because that's how I feel a lot of times. I'm a pawn. All these guys and ladies are making big decisions, and they know as an optometrist, as a health professional, I just want to do a good job, and I will accept what you pay me, and I will follow the procedure that you give me. So those are inflection points. So, are these challenges or are they opportunities? I challenge you to look at them as opportunities because they are. That's how we grew. That's #1 rule, right? Is that if 99% of your colleagues are looking one way, you have to have the courage. You have to have the fortitude to just look the other way. And that's where the juice is. That's where the good life is. It's not following the 99% in anything in life for that matter. So before I let Noah join in, this is our office today. You saw our office with the Ninja Turtle. It's beautiful, and it's almost 10,000 square feet and things like that. But we don't view it like this. We view it like this. Our office is built on pillars, and each pillar is a subspecialty that we offer in our office. One pillar is contact lenses, the other pillar is eyeglasses, the other pillar is eye exams, maybe vision therapy. And Barry, Ivan, and I noted about 20 years ago, some pillars were very brittle and some were very strong. So the pillars that we decided in 2001 to really focus upon and ignore the other pillars, which wasn't easy, guys. It's not easy for you. Wasn't easy for us, trust us, was something that had a high barrier to entry. And for us was corneal reshaping and vision therapy. And I did a vision therapy residency. Noah did a vision therapy residency. Ivan did a medical residency at Baskin Palmer. Barry did a 3-year public health service where he did vision therapy. So the lesson here is you don't have to specialize in the subspecialty, you have to commit to it. So this is our office in a nutshell. It basically, the reason we brought Noah in, besides being Barry's son, and we're going to talk about that, we needed a partner. We need a strategic partner that allowed us to grow these profit centers on the side. See, most ophthalmologists, optometrists are right in the middle. Refraction, glasses, contacts. We realize those are commodities. Even the eye exam now is commodities. So we are focusing on that periphery there. We need help because those peripheral services need total focus. If you're a jack of all trades, you're just an expert of none of them. So Noah did a residency at Salis of vision therapy. It's not the vision therapy he learned. This is the reason we brought him in. It's the philosophy of care, of focusing on one specialty. Ivan just did medical, yet he understands the philosophy. And that's why we brought him in. It's not that Noah knows VT and we brought him in to do VT. It's actually the philosophy of providing a specialty like VT. So Noah, why don't you jump in now? I talked enough. Why is corneal reshaping similar or dissimilar to a service like vision therapy?
Well, that's a good question, and it might come as a surprise to some people, but the two are actually virtually identical. Obviously, yes, they treat different conditions, but from a practice management standpoint, they're essentially the exact same. Basically, they're both specialty services that not many providers are providing for their patients, and they have a very high value to their patients. And by high value, I mean that something like a CI or myopia is not going to get better on its own. And people with eye coordination issues or convergence insufficiency, those children might be struggling in school, and to the parents, that's obviously a very important issue to them. Same with our patient population that get treated for myopia. Those patients understand that myopia is actually a disease, and it carries far greater implications than just an increased dependence on glasses. So from that standpoint, they're very similar, and patients are gonna put a lot of, they're gonna come and pay money and travel far for these services. So in that sense, they're both profitable. We don't take insurance for either of them, so we can get reimbursed fairly for our time and our expertise that we're investing in these patients. We develop long-term relationships with these patients because they both require long-term care with appointments that span over years. Even in some cases, our ortho K patients start with us as children, and we still see many of them as adults. And same with our vision therapy patients. The active therapy stage might only last a few months, but they come in for reevaluations frequently every few months to make sure that they're not regressing and that they have retained all the improvements that they've made. Now, unfortunately, they don't share all positive properties. There's negative properties as well. And we get met with a lot of skepticism about these services. Patients will question all the time whether or not they actually work, if they're safe, if there's research that supports these services. And you really have to take the time to explain to them and alleviate all their concerns. And we often will share research papers with them. We'll share statistics on safety and efficacy so that we can make sure that we're all on the same page and that they're motivated to receive these services. Now, it's not just the patients that have skepticism about these services. It's obviously a lot of providers as well. Otherwise, more people would be providing these services. So, like Dr. D said, there's a high barrier to entry. People think that they aren't trained well enough. It's too much work to do it. It might not be profitable, and it might not be successful in the long run. But what Dr. D is stressing, and what I have learned after working with him and being in the practice, is that it takes intense focus. You have to commit yourself to this.
Right.
And you have to make sure that you're putting all your effort into growing these specialties and you're not doing a little bit of everything. Because if you're spreading yourself out too thin, you're not going to be able to grow any of these specialties. So why I decided to join the practice and go into optometry in general was because I spent a lot of time as a youth in the practice observing what they were doing. So I actually got to see these services in action from a young age, and I could see the way that patients would respond to the services, how grateful they were for the care we were providing, how they respected us and listened to our medical recommendations. And also I could see that my father had a very good quality of life compared to some other professionals. Obviously, he made a comfortable income, but more importantly was by focusing on these specialties and growing them, he was able to have more time to devote to other things. For instance, if he was in retail, his success would probably be measured more on volume or on frame sales. Basically, how many people is he getting into the door and how many products is he selling? And it's a rat race. You're on a treadmill if you're doing that. But by focusing on specialty care and corneal reshaping and vision therapy, you could see one patient in a morning or two patients in a morning and make exceptionally more money than you would have if you had seen 10 patients or even more than that, because they're willing to pay a lot of money for services that they know their children will need. And that's another point, is most of these two specialties specifically cater to children. And anyone who deals with children will know that parents will do virtually anything to give their children the care that they know they need, even things that they might not do for themselves. So in that sense, you can be very successful by providing these services in a different way and improve your quality of life.
Yeah, that was really good. And I'm going to emphasize, this is not about corneal reshaping and about VT, because I'm convinced, because I've been in the field so long, I could pick any aspect of optometry right now, because I've been doing it for over 3 decades, and be very successful in it. But it needs certain attributes. So for example, if I wanted to do just glasses, you can't do glasses like everybody else is doing. I have a friend who's very successful. He's an optician. He sells glasses in Manhattan. There's a Warby Parker down the road, and there's probably a dozen to several dozen eye professionals. The reason he does well, when you walk into his optical shop, there's not a frame showing. They're all in drawers. He's like walking into a custom tailor or custom designer. They are going to take the time, just like Noah said, it's no different than anything else, to find the right frame for you with the right prescription. It's going to be an event, and that person will leave spending $1,000 or $2,000, whatever they spend, but they received value from it. It wasn't they were shoved in there with a bunch of eyeglass plans. So I want you to know this is not optometry. If you haven't read this book, I love this book. It's by a cardiologist who lives in Queens, practices in New York, and he had a PhD in physics, and his father said, become a doctor like your brother, become a cardiologist. You'll make some money, for God's sakes. You know, all this school, you're a physicist. And he wrote this book called Doctored, The Disillusionment of an American Physician. He's so honest here, guys, so you know it's not optometry. It's health professionals. It's our health system that stands today. And a quote that I took out of the book is, did I really want to become another private practice grunt over testing? See, he talks a lot about that, how he just didn't feel comfortable testing for the sake of testing so he gets reimbursed. He keeps talking about that, kissing ass for referrals and fighting insurers to get paid. So he really fought the system, and his wife is a physician, and they were suffering financially. He wanted to do the quote unquote right thing. He wouldn't play the game, and he paid a financial price for it. You know, this is opposed to Ernie Bowling, who is the editor of Optometry Times, who actually brought this book to my attention. And he wrote this article in 2015 that really describes what I'm going to bring to the table. Is what kind of doctor do you want to be? See, when we get out of school, our parents, everybody wants you to earn a damn paycheck. You've been going to school for like 8 years after high school. It's time, man. It's time. You're tired of just like scraping by. You want to drive a car that's reliable, if not good. You want to live in a house. You want to have a nice house with a washing machine. You just want a life. So your first instinct is to get on the treadmill and get a job. I'm here to tell you, you guys didn't get into optometry for a job. Trust me, none of us listening to this program got into optometry for a job. What we got into it is to help people and be rewarded in proportion to how much we bring to the table. And something went awry where the goal started being just get a job. The more patients you see, the more money you're going to make. And that's the goal. And it doesn't work. Any of you out there, you guys work so hard. I mean, really hard, long days, seeing several patients, hoping you're not missing anything, because people just think we go better 1, better 2, better 3, better 4. And you know, that's a bunch of BS. What we're really saying is, how come this patient's not seeing 20/20? I better look at their field. I can't miss a swollen nerve. I can't miss anything, a pupil, a cover test. That's what we're thinking when our mouths are saying, is it better this way or this way? Nobody appreciates that more than the people listening here. So Ernie says, what kind of doctor do you want to be? focused on your craft and your relationship with your patients, since this is the only thing we can control. So he's asking, what kind of doctor do you want to be? A great question for all of us, no matter our health discipline. So we're here to tell you, and I have no reason to lie, guys, is if you focus on the doctor you want to be, it will materialize. I'm going to tell you, it looks easy now because you're seeing the end product, just like you're seeing Jeff Bezos. He's a genius and he created Amazon. If you pull up the news headlines about Amazon in 2001, they would say this guy's going broke. There's no way he's going to make money. We're just seeing the end product. So what lessons have we learned is that you can do anything, but you can't do everything. So the number one failure that everybody makes, like Noah said, is the one thing he learned in the 5 months he's been there is we focus. We're one-trick ponies, and I encourage you to start focusing. Barry just takes care of VT. I just take care of myopia control. Noah's in both clinics now, very little primary care, deciding on which one he's going to fit into. Ivan is just medical. He helps me in the myopia control, but his whole focus is medical. That 99% of us, I just came back from a global specialty lens symposium in Las Vegas, and I'm giving talks on myopia control because it's hot right now. And people are coming up to me and saying, Nick, you should do LipoFlow. Nick, you should do XYZ. And I said, I can, but I can't be good at it. The secret sauce that Noah's trying to talk about is you gotta provide care. You can't just do VT for the sake of doing VT or myopia control or even medical testing. You gotta take the time to bond with the patient. So the number one rule is you could do all these specialties. You guys are much smarter than me. The thing is you can't do all of them. So in our office, this is the profitability of our specialty centers. So it's not by accident that Ortho-K is on top, and I also focus on it for the past 15 years because I was working like a dog, like many of you. It was 2000, maybe 1998, and I was seeing 4 patients an hour exams and 2 checks. So that's 6 an hour. I had pre-testers, I had everything. What I had was a huge headache. I felt just depleted. I felt I wasn't helping anyone. I came home grumpy. And this is the kicker. I wasn't making any more money than when we used to see 3 exams an hour. So that was a revelation. I was seeing 4 exams an hour now. I used to see 3 an hour and wasn't making any more money. So that was the impetus. It's not because I like to fit a rigid, hard lens where 7-year-olds put in their eye at night. I'm going to have Noah share with you. He loves doing VT like I love doing Ortho-K, and we love the success stories. But there are times where that sweat drips down our back because the patients demand results. Medical can work. I am telling you, medical can work, but you just can't do everything. You can't fit your glaucoma check in between your contact lens check, in between your primary care exam. If you're going to do medical, do it the best you can with the best technology, and understand that your reimbursements are controlled by insurance companies. But you know what? You're the best at it. You'll develop good referral sources, but that's what you do. So here's our model for success. Focus on a specialty that has a high barrier to entry. So soft contact lenses, very low barrier to entry. Vision therapy, very high barrier to entry. Low vision, very high barrier to entry. Notice we don't do it. It's because none of us have shared a passion for it. So if we just did these subspecialties for the money or for the gross income, it wouldn't be fulfilling. So when Noah talked about the commonality between Ortho-K and VT, they're so similar. I love kids. I love helping kids in a unique way. I love when kids grow up to be adults and they give me a hug and they're 3 inches taller than me. I love when they become physicians or plumbers or stockbrokers. That's why I did VT. That's why I migrated to Ortho-K. confirm that specialty is profitable. Obviously, you don't want to go into something that you're just banging your head against the wall, and confirm that specialty fulfills your values. And that's the key. We're here to tell you, me more than Noah, is we have no reason to lie to you. We're not getting paid for this. It's my value to train younger doctors like Dr. Moore and Dr. Noah and so many others, because I'm here to tell you, and I have no reason to lie, is that it's possible. You just have the fortitude to say, God damn it, he's right. I'm going to do it. I'm going to do it. So Ortho-K fills all those things. High barrier to enter, profitable when fees are calculated intelligently. And if it fulfills the values I value as a doctor, respect, because when I was seeing 4 patients an hour, there was no respect. Patients were mad at me. Insurance companies were auditing me. My staff was mad at me. My wife, my kids were mad at me. There's just no respect. There's definitely no autonomy. It's like the insurance company is telling me it's $50 for the exam. Now it's $70. Now it's $35. We don't cover this. There was no autonomy. Nobody appreciated me. I didn't appreciate myself. And, I didn't feel like I was helping patients. With Ortho-K, for me, I feel I do it better than most. And it's not the fitting. What Noah's going to bring to this YouTube live is it's not the fitting. Noah, did you ever fit an Ortho-K lens in school?
Just in a lab once, and when I got to the practice, I virtually had no experience, but I was still able to discuss it with patients and sell them on the idea. And then obviously I would have help from you to design these lenses. But the more important thing is making sure that they are on board and understand. And the easier part is learning how to fit them. It's been 5 months and now I feel confident fitting them. But for the first 5 months, I had no idea what I was doing, and we were still very successful.
Right. And the way he sells it, I could tell you, Noah and I butt heads only one time every day, is he wants to do things the right way, and he wants to know it's evidence-based. So when he's saying selling, he's not selling, he's selling his time, because his first Ortho-K eval was like 2 or 3 hours, just like mine. His VT evals are 2 hours. Because what he's doing is educating. It's really not selling. And if he feels this patient can't benefit from whatever he's talking about it, he's not going to do it.
And that's exactly it. Is I know they're going to benefit from this. I know that, they're 7 years old and they're already a -3. And if we don't do something now, they're going to be in trouble later in life. So what my goal is to make sure they understand that I just want to help them and make sure that they don't have any concerns about the technology. So it takes time to do that.
And our residents come in thinking they're learning VT, and they are, but that's just a byproduct. VT is, like he said, Noah learned Ortho-K in I don't even think it's 5 months, but let's call it 5 months. But what he came in knowing is how to articulate a service in such a high value that the patient will commit to it, will trust him. And that takes time to develop. It's almost innate. So all our residents, we're just so proud of them, because they came in very smart. They came in thinking, I want to do VT, but really what they learn is how to design a life so VT feeds their lives. And that's really the importance. So that's number one. Lesson number one is you can do anything. Trust me, you guys can do anything, but you can't do everything. Number two is you need persistent focus. Noah said it. I'll say grit. Let me tell you something. When we expanded to that building I showed you for 9,000 square feet, anthrax hit that same year in 2001. 9/11 hit that same year. We had borrowed almost $2 million, Barry and I. We just took on Ivan as a partner who just gave up his practice, and he just got married. And we were going to go broke, guys. We had no patience. Anthrax happened right in our post office, 08690. We were broke. Our accountant would say, you got to have your staff fill up the parking lot because it looks like a ghost town. We had no tenants. We had no money. There were months where Barry and I did not take a check home. And our wives are looking at us like, what the hell's going on? If we didn't have the grit to say, damn it, we're going to stick by this. And that's when the specialty practice grew, because we had dropped all these plans. There ain't no money coming in. People aren't going to come in, and we're not in the book. And certainly not going to come in and get anthrax, God forbid. Cipro was given out like candy in our community. The mayor drove down someplace to our Army base in Cherry Hill to get Cipro pills to give out at the township. That's where we were. If we didn't have the grit, if we didn't have just the growth mindset, and what Noah will never see is the reason I even became a partner is I would take this projector that was owned by SIBA. And I said to SIBA, I'm going to go lecture on SIBA Dailies, which just came out, because I couldn't afford a projector. And I'd go to schools, Chinese schools, anybody who listened to me, and talk about the myopia epidemic. Barry would take that same projector and lecture to PTs, OTs, schools, anybody who would listen, because we had no patience, and talk about vision therapy or concussions. And then we weathered the storm. Most would have said, you know what? I'm going to start taking VSP and IMED and every other plan. But we knew we weren't going to do that. So you need to have that grit. And the third lesson is you have to have faith. And this quote is very strong. People feel much more responsible for a decision that they make actively than if they choose to do nothing. So what that means, if I choose to do nothing and just say, you know what, I'm going to accept all these plans, I'm going to stay where I am. The story I didn't tell you is I opened up my office the year I graduated my residency. What I didn't tell you is I started working for an optometrist. I wasn't liking the way it went. And after 3 weeks, he calls me up on a Sunday and he fires me. He fires me. And now I have to explain to my wife, that's been waiting a long time for me to graduate, and my parents that have been waiting even longer, that I had one job, my first job, and I got fired. But that day I made a decision, is I'm not going to do that anymore. I'm going to do it my way. I'll go down with the damn ship, but I'm not going to do it again. So most people don't make that decision and say, okay, I'm just going to go with the flow. So you can't blame anyone. If our office went down, the only two people you can blame is me and Barry. That was it. So you have to have faith in yourself that yes, you will step in the potholes. The poop will hit the fan more than you ever would know, but you will weather that storm and you'll be so much stronger for it. So in conclusion, and then we'll open up to your questions, is it reality or myth, this thing that we call practice independence or practice autonomy? I'm here to tell you, I have no reason to lie, it's so true. But unfortunately or fortunately for you guys, most can't do it. You have to confirm your actions align with your true values. Yesterday, Noah and I were writing a book together, and it's on the myopia epidemic. The only argument we had is, he goes, Dr. D, I will not put anything, I will not agree with the statement you wrote, because I cannot find research that validates it. And I'm saying, Noah, you made it explicitly clear that you said it to me 10 times, but that's his values. That's why he's there. He values honesty. He values accuracy. He values his own reputation. He doesn't want anything in writing that cannot be true. So you can't go against your values. If he just said, you know what, I don't want to upset Dr. D, I don't, I just want this stupid book published, he would just say, go ahead, do it. It's no, he's stuck by his values. And number two, as I told you, you can do anything, but you can't do everything. Number three, I told you some honest there. You got to be persistent. I got fired 3 weeks out of my residency, and I just kept going. And you have to have faith. You have to have faith in yourself. So we're not crazy. Trust us. We're just happy. And I'm going to do a plug that go to Vision by Design if you want to learn more about orthokeratology. It's in April. If you want to learn more about vision therapy, COVD is the same month, probably the same weekend as that. I run a Facebook group. You just have to email us, or Antonia will tell you what it is. And, we give a great workshop. So we're going to open up to questions.
Yeah, that was excellent. Thank you for sharing all that information.
You're very
And
welcome.
there's some questions that come to mind. I mean, some of these you've touched upon, I suppose, but let's just say, for that average private practice OD out there, you've got a practice and you're one of the jacks. You do a little bit of everything. Your practice focuses primarily on eyeglasses, contact lenses, exams, and you're saying to yourself, man, I'm just getting really tired of going in every day, seeing that 4 patients, 5 comprehensive exams an hour, just cranking them out. I'm going home grumpy. You know, where do you start? I mean, what you're saying to yourself, I want to change something here. I want to add a specialty. I mean, but I'm by myself. What do you do? Where do you start? What do you look at? How do you start to develop a specialty in what primarily was or primarily is just a general private practice? I mean, any strategies?
Noah, you want to jump in?
Well, considering that you're the one who did it yourself, maybe you should start.
Yeah, it's easy for me. First of all, are you talking about someone who's employed, Antonio, or you think someone who has their own practice?
I guess you could probably look at it either way. I mean, I think that if you're employed, you're looking to grow an aspect of a practice. I guess the situation is a little different depending on what scenario you're in.
Yeah,
But let's just pretend you've got your own practice. It's
right.
a
So,
single. Hmm.
yeah, yeah, that's very easy. You got to make time. It doesn't matter what you do, low vision, glasses, we made that clear. So what we did is we evaluated the insurance plan. So VSP was almost 20% of our practice. So if we were making $2 million at the time when we dropped VSP, I'm just using it as an example, we lost $400,000 gross. But that was the last one. That was the big guy for us. So we started dropping the little plans earlier in the 90s. So the number one recommendation, you got to make time. If you're slow and you opened up cold, you don't have to drop the plans. Keep them. Just make the time to develop the specialty. So Noah, why don't you tell us your first few specialty care patients, how much time we allotted for you to develop the relationship that's needed? So you could talk about VT or Ortho-K.
Well, they're almost both the same. When I first started, there were a lot of days in the beginning where I might only see one patient in a morning. And it could be one ortho K consult, or it could be one vision therapy exam. And it didn't matter that I was only seeing one patient. Maybe I'd spend 2 hours with them. Maybe some patients that they were more complicated, I'd spend 3. But I would convince them that I can help them and that the services I provide are high value. And now they're willing to pay a lot more money than had I seen 5 patients in order to get those services because they know it'll benefit them. So just because you're not busy doesn't mean you're not going to be successful. And I think another important thing, which is actually something that Dr. D has taught me over the years, is that you need to, it's okay to take a day for yourself so you could focus on the practice. Instead of working 6 days a week, like some people do, work 5 days a week and you don't go golfing on the 6th day, but you sit at home and you strategize about how to grow and what your next moves are. Because if you're always just seeing patients and cranking patients out and being a technician, you have no time to strategize and plan ahead for the future.
Yep, that was excellent. Yeah, it's kind of like you're on this car, you're running out of gas, but you don't have time to stop to fill up. So it's kind of like you have to make the time. If you're cold and you're slow, slot out that time. It depends what your subspecialty is. If I went to do low vision, I could be very successful in low vision. I would be slow, Antonio. I would go visit every retinal specialist and say, I do low vision and I'm really good at it. And when they come in, like Noah said, Dr. Noah said, is I'll spend an hour or two because I either allotted that spot, I have that time. And when they go back to that retinal specialist, they would say, Dr. D spent so much time with me. that retinal specialist would send so many more patients. I'd go home visits if I was a low vision specialist. If I was a vision therapy specialist, I'd go lecture to schools. I'd lecture to OTs. I'd lecture to anybody who would listen to me to get that one consult that Noah was talking about. And then that's my golden opportunity to really expand on it. And Ortho-K also. And he hit on one big thing that I missed out upon. He says, you don't have to be busy to be profitable. I'm here to tell you, the busier you are, you're probably less profitable. It used to be when I went to school, the goal was to be busy. That paradigm no longer works. You better off being less busy, high touch, high value, and less volume. You can't have it both ways. You can't be, you don't go to a Ritz-Carlton and feel like you're at a Motel 6 or a Marriott even. You know you've stepped into a Ritz-Carlton. You just know it from the time they say hello by your name. You can't be both.
And Dr. G brought up a good point that if you're good at what you do, then the patients will take notice, the referring doctors will take notice, and you'll get a much better referral source from them. So primarily for orthokeratology, our best referral source is the patients that we're already seeing. They go home and they tell their friends and families, we just met the most caring doctors that we've ever met. They took the time, they took time that no doctor has ever taken to answer all our questions and explain everything thoroughly. And it's the same with vision therapy. Our biggest referral source for the vision therapy is doctors that refer to us. So for instance, there's a concussion specialist who's not even actually that close. She's maybe 40 minutes away, an hour away. And she's referred a few patients to us, and they've gone back to her and said that I'm cured. I don't have any more of the symptoms I had following my concussion, and the treatment works beautifully. And now she sends every patient to us. Anyone that has lingering visual symptoms after a few months will come to us because she knows it works, even though there's people that provide the same services much closer and much cheaper. But if they go into vision therapy in some of those practices and they take twice as long to get better, or they don't improve after several months, they go back and they tell her that, and she no longer refers to them, and we'll get those patients instead.
Yeah, we have a question from a viewer. Benjamin is a new practice owner, solo practice, 2015 grad. He's doing some Ortho-K and he's got some Ortho-K and scleral lens experience. He's looking to grow his practice. He wants to know, it sounds like you drop your vision plans before really getting into your specialties. And if you could do it again, would you do it the same way, or would you have kept those plans while trying to grow your Ortho-K practice or Ortho-K component of your practice?
Yeah, that we definitely would encourage you to keep the plans. We didn't drop them all at once. We dropped them. We had, Antonio, when we started, we just had 3 plans. I think of Medicare, Aetna, and maybe a Blue. That was it. By 1996, we had 50 insurance plans. 50. It was like it was a cluster. So we started dropping them very strategically. So he opened up cold, or she opened up cold. She needs money, or he needs money. So keep the plans, but have a bigger picture in mind and say, okay, but when you see that Ortho-K patient or scleral, because your demographics are different. For the scleral patient, you need them to go back to the corneal specialist and say, my gosh, I've never seen this way. It feels great. For the Ortho-K, they got to go to their friends and family to say, this doctor, she spent so much time with me. Johnny wasn't seeing well. She talks to Johnny. She gives Johnny snacks. She's more than just this average doctor. So even though other doctors in your community offer Ortho-K for much less than you do, they're going to refer to you. But if you stick that Ortho-K patient in a morning or afternoon or evening where you're doing all these insurances, you may as well not do it, because they just become a number. So if there's one lesson here is decide on what you're going to focus on. You could have peripheral stuff. We're not saying drop it and starve. We're just saying have a bigger picture in mind.
Yeah, thank you. I guess another question that kind of comes to mind is, you mentioned it before that and something you're passionate about is the myopia control, and you're starting to or doing that in your practice anyways. Where do you start with that? Because I feel like it's something that's the literature out there. It's hard to figure out where to start, what to do. Are you using rigid lenses? Are you using atropine? I mean, I know that this could probably be a whole lecture in and of itself, but just for the for the practitioner that wants to just kind of figure out how to get started into that kind of specialty, I mean, what are you looking? Where do you start? What do you do?
Okay, I'll start. I just gave this talk. It's worth the price of admission, guys. Myopia control has nothing to do with drops, ortho-K, dual focus soft, zero. Hygiene, visual, nothing. What it has to do is understanding the demographic that's interested in myopia control. So for example, there's a myopia epidemic. We can debate on it, but Noah and I are pretty certain that the numbers don't lie. The World Health Organization states by 2050, just 30 years from now, half the world will be myopic. Over 3-4 billion people will be myopic. But there's also a obesity epidemic, and we know it, but yet there's some people that are doing something about it, but we know a lot aren't. So just because there's a myopia epidemic doesn't mean the population will be interested in prevention. Does that make sense? So
Yes.
If you just say, I'm going to start by prescribing atropine or ortho-K, you're going to sink. You're going to sink so bad, because the demographic that's interested in ortho-K drops or visual hygiene, they view myopia as a disease. They will suck you dry if you don't take the time to talk to them. So I think this is a good example. Noah, why don't you talk about Friday's patient? I was in Las Vegas lecturing on this very topic. Noah, after 5 months, is seeing all my ortho-K patients, just 5 months. And he will tell you about a patient that was only wearing their ortho-K lens. Was it 1 week, Noah?
1 week. It was their 1 week follow-up. We had just fit him, and we were experimenting with a new lens design. And what you have to understand about this patient population is they can be very intense, and they do view myopia as a disease, and they don't play around with it. They want immediate results. And they want it to work right away. And this particular patient came in, and unfortunately, his vision was about the same as when we started. It hadn't improved much because it was a poor lens fit. And we explained to them going into it that we often will go through multiple lenses to achieve the right fit and to achieve maximal vision and comfort. And it's not uncommon to make changes early on. And even though we spent a long time explaining that, the patient comes in, the vision's the same, and the mother actually was very angry, and she treated us rudely and was unfair to us. She kept insisting that we weren't, helping her child well enough. And if, how come these lenses aren't working? We promised they would work. And I tried to explain as calmly as I can that it's normal, and we can easily refit him into a new lens, and it's nothing to worry about. It's 1 week in. But if you're fitting that patient in the middle of a busy patient care schedule, you can never, ever take the time to explain that to them. I spent a long time with her, and I was able to calm her down, and now she's happy again. And I made a new lens for him, custom designed with different software, and we delivered it to him because I can recognize that the lens we fit him in didn't work, and that was, our fault. But the bottom line is you have to be willing to deal with these kinds of patients and be willing to spend the time to help them. Otherwise, if I had stopped right there and I said, I have another patient, I'm sorry, I'll do my best to fix it, she's going to go back and she's going to tell
Yes.
all her friends not to come. They all use a messaging app. She's going to go on that messaging app and she's going to tell hundreds or thousands of people, don't go here. They aren't good at what they do. When that's just not true. It's just how she was perceiving that one encounter. But fortunately, fortunately that is a minority. You know, most of our patients we're successful with, but you have to be aware that you're more likely to encounter that in this patient population and other patient populations.
Right. And I'm going to stop him right there. Now, he had 3 patients an hour scheduled, 20 minutes each.
Mm-hmm.
He spent an hour with that patient.
Yeah.
And our program, Antonio, is 2 years. She's 1 week into the program. The
Wow.
program's 2 years. She paid for it.
Mm-hmm.
And she's all over everybody in the vicinity because, like Noah said, they view myopia as a disease. So myopia control is understanding the demographic, the mom who wants to stop the myopia from getting worse. It's the mom that starts to cry. Like you're in the exam room and you say, Johnny increased about a quarter of diopter, and they tear up. This is myopia control. You will find out whether to start atropine or RGPs or soft. That's the easy part. Handling the demographic. I'm going to kill this topic now. Let's talk about vision therapy because they think, well, I'll do VT then. One of your first patients, and I don't do VT, Antonio, but I hear it. Noah and I share an office with all the doctors, and talk about the patient that you were prescribed some prism that I've never heard, your vertical prism and horizontal prism, and then they came back for an RX check. It could have been 2 RX checks. Do you know who I'm referring to?
It's hard to say because you're describing a lot of patients like that.
But the patient was upset. They got the glasses and you prescribed, and you went in there, and do you remember this patient?
I can remember a few patients that we prescribed complicated prism prescriptions for, whether it's a congenital fourth nerve palsy that decompensated in, emerging presbyope, which is one of the patients that we saw early on. And he came back for multiple RX checks to get the prescription right. We would give him a prescription. He would say he didn't like it. We'd rework it. He'd come back a few weeks later and say, I like the first one better. Can we switch it back? Then he'd come in and say, can I actually have this in a progressive lens? And it can be a real headache. And there was another patient I saw early on. It was a very sad case, but it was a teenager who was diagnosed with a brain tumor. And he had it removed, but it left him with a third nerve palsy. And we did our best. He had constant double vision. So I did my very best to fix his double vision. And it was a very complicated prescription. And it didn't work, which is the case sometimes. And he ended up coming back. He was very upset because he was so excited to finally fix his double vision, and it didn't work. Now, fortunately, for both of these patients, we had successful outcomes, but it took multiple visits, and it took a lot of time on the doctor's part to get it right.
Yeah.
You're not going to get it perfect every time.
So if we rushed either of these 3 cases, they would go back to the referral source and they'll just say, listen, I went to Dr. Noah. I spent a few $100 or whatever they spent on the lenses, and I can't use them. It was no good. Dead. Like you said, the Ortho K patient gets on an app, Facebook, some type of social media app, and says, Dr. Noah, he fit my son after a week. My son didn't get better. Done. So the advice to all of you out there is when you decide to bring in the specialty, have faith that you'll learn it. That's the easy part. The hard part is understanding what demographic is interested in this and making sure you service them. At least you make sure you have the time.
And Antonio, to address your original question of what are the nuts and bolts, the technicalities of actually incorporating this into your practice, that's where these meetings come into play. Something like Vision by Design. They have a boot camp that shows you how to get fitting sets, and they have a wet lab where you practice fitting these lenses. And they talk about incorporating it into your practice fee schedules, and they also have advanced classes. We give our own Supercharge Your Practice lecture so that we can show how to maximize profitability. And COVD is great for vision therapy. So if you actually want to learn how to get these specialties into your practice, I would encourage anyone who's listening to go to these meetings and go to these boot camps and learn that way, and start with the easy courses and build your way up to the advanced courses.
Yeah. And
Yeah,
just
that's
understand, learning the specialty is the easy part.
Mm-hmm.
Fantastic. Well, we have one more question here from a viewer, and it kind of, maybe you could weigh in with some thoughts on this. So essentially, you know, I'm a doc, and I have an interest in vision therapy, and I'm going to go to you know, Mr. Jones's practice there, and I'm going to say, hey, or Dr. Jones, I'm going to say, Dr. Jones, I want to start to do vision therapy. I'd like to, you know, start providing that to you know, as a subset in your practice. What's the best way to go about that? I mean, not just on a getting started basis, but a revenue share basis. You know, is that kind of, well, you know, I'll provide the equipment, you know, allow me to perform this in your practice, or, you know, maybe you provide the equipment and I'll help you grow this portion. I mean, what's the best way to get started in that, and what is considered, I guess, fair in terms of just sharing revenue and you know, building a component of a practice for someone?
Yeah, we discussed this with our residents. It's somewhere around 60-40. It could go either way. So let's say I come to you, Antonio, and say, I want to bring in VT. You say, Nick, I'll give you my room. I'll even buy the equipment. What do you need? And I said, I need about, I don't know, $10,000 worth of equipment. I'll give you the room. I'll set you up. And I'll also help you with the ancillary staff, you know, my receptionist. So basically, you're going to come in and do that, and you hire your own therapist. Then I think it's fair that I pay you 60, and I get 40 or 50, somewhere around there. If you think I'm not using my office on Saturdays, come in, use it. You know, you could, you know, bring in your topper or whatever, your vectograms and your aperture rules here. Then it could be 70-30, you know, and I'm just paying you rent at that point. Or it could be 50-50. But this is key. You want to make sure your values with the person you're entering are similar. Because it does, if it's going to be successful, it's got to work both ways. So it's either 50-50, 60-40, where one of you take the 60 and the other one take the 40. But it's got to be, you know, honesty. And that's the hardest thing to get. That's why 80% of partnerships fail after 5 years. Then the remaining 20%, another 80% of that 20% fail in the next 5 years, because the values go awry. You know, so I would give advice: know the person you're going to bed with first before you go to bed with them, and then just make it as fair as you can, because if it works, it's going to work for you and them. If it doesn't work for you, you're going to take your patients and leave. And if it doesn't work for the practitioner, they're going to throw you out. So to answer the question, it's really got to be around 50-50, 60-40, rarely 70-30. You got to make it worth it, you know.
Thank you. That's great. That looks like that's the last of the questions. So if you have any closing thoughts, any closing comments, the floor is yours. But thanks again for joining us tonight, and we hope you all enjoyed it. Of course, we're going to be you can watch this on YouTube at any time. It's going to be available to everybody. But I'll leave the floor to you, Dr. D, and to you, Noah, there, if you guys have any closing remarks.
Go ahead, Noah, you go.
Well, I just want to thank everybody who's watching for tuning in. And I want to thank Antonio for having us onto the program. We're happy to share our insight and hope that what we said helped some of the people out there that are watching.
Yeah. And I want to thank you also. And I also want to give you some pain. We gave you there's a lot of pain. I've been doing this, guys, for over 30 years. It goes like this, and your patients tell you that. And now my colleagues are calling me up and saying, Nick, I want to get off the treadmill. I've been doing it for 30 years. Do you want to buy my practice? Do you want to buy my records? Can I come in and work with you guys? That's how quick it goes. So the pain is, there's no better time than tonight to change what you're doing if you're not happy with it. That's all. We're here to tell you, yes, it's possible. It's not going to be easy. If it was easy, everybody would do it. But the pain of it all is your career will quickly be over. And you don't want to be in the same spot that you are now. If you don't want to be there, you got to change.
Well, thanks again for joining us tonight. We hope you all enjoyed it, and look for us on YouTube. You can reach out to me if you have any questions, and I can always forward them along. But we'll make the contact information available in the YouTube description. So check for that as well. So have a good night, everybody. Thanks for watching.
Good night.
Good night.
Good night.